Hello, my name is Mary Sweeney, and today we'll be talking about the theory of reflection. The annotated bibliography that I chose this week is The Use of Reflection in Medical Education by Saunders. First, we'll do a background on reflection, and then we'll talk more about the annotated bibliography source. John Dewey was the first educator to define reflection in 1938. Terry Borton then continued to build upon Dewey's thesis and coined the phrase, "What, so what, and now what?" Donald Schoen then spoke about a learner-centric model in which there was a reflective loop of action and stimulus for the learner. The theory continued to evolve as David Colm developed his cyclical theory of experimental learning, in which 4 phases were described. First was the concrete experience, then the reflective observation or review of that experience, the abstract conceptualization, where the learner would develop new ideas or modifications, and the active experimentation, where they can then apply these new ideas. Graham Gibbs then talked about a reflective cycle of growth and development with Q questions, as shown here. Modern approaches continue to align reflective practice and experimental learning. An example was Jennifer Moon in 2004, who continued to build and expand by linking existing knowledge to an analysis of the relationship between a learner's current experience and their future action. Some limitations that have been described with this theory are that it is a self-regulated learning process, meaning that the learner needs to be fully engaged, motivated, and have a clear goal for their reflection. There may also be difficulty in applying the phases of reflection depending on the learner. There's a need for instruction and framing, and oversight and feedback are needed by the mentor or expert. So now getting into reflective practice and how it can pertain to medicine. It is a key practice for health professionals to make sense of complicated situations with patients. 3 approaches can be used in order to apply reflection to medicine. The first is applying it in learning, and this is when we utilize the different phases discussed to interpret and integrate an experience into our existing knowledge. By doing so, we're able to create new or expanded knowledge. An example would be a provider performing a procedure better the second time after learning from their mistakes the first time. The second is a reflection to develop a therapeutic relationship between the provider and the patient and/or caregiver. This can help develop patient-centered care, which has been shown to improve outcomes and patient satisfaction. The third is reflection to develop professional practice, in which we use a complex integration of knowledge and skills. Some educational strategies that we can use in order to integrate this theory into medicine are described here. The first is guided reflection, and this is when a mentor or supervisor can model the theory for a novice provider in order for them to facilitate and create a supportive environment for the learner to reflect on their experiences. There are ethical considerations within medicine as well. If a learner has to reflect on a prior experience, it may elicit strong emotions. An example could be reflecting on a code situation where the patient expired, or thinking about the current pandemic with COVID. Creating a safe environment in a group setting or with facilitation can help with this. Motivating the learner with goal setting can be helpful, using metacognitive skills for reflection, and then things such as storytelling and writing can also help. Another application of this theory can be used within simulation in medicine. Simulation can be used for procedural training. It can also be used to create real-life scenarios in order for providers to practice and perform better when the situation arises with patients. Simulation typically involves a pre-briefing where you talk about what's going to happen during that simulation, the actual scenario itself or procedural training, and then a debriefing, which should be learner-centered. This reflection can help to optimize learning within simulation. Usually the debriefing has 3 phases. The first is a reaction, where you explore what happened and what emotions were impacting the learners. The second is an analysis, where the facilitator can use open-ended questions to prompt discussions. And the third is a summary, where you apply that insight to the analysis phase. An example of this was a recent study with dental hygienists, where they used the Kolb's theory to develop a debriefing reflection rubric. This was successful in measuring the learner's level and quality of reflection during simulation debriefing. So this is a potential to use the rubric as a universal instrument in the future. If you have any questions, please let me know. Here are my references. Hopefully you learned something from today's short video, and I'll talk to you soon. Thank you.